coming to today's topic, steroid resistant asthma. So, about the introduction, let's have a short look at what is the definition of asthma. So, asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity, together with variable expiratory airflow limitation. So this is important that it varies in our time and intensity. This is the important part of the definition. So airway inflammation and immune activation play key factors in etiopathogenesis of asthma, and about 95% patients respond well to beta 2 agonist and corticosteroids with or without add-on therapies like montelukast and long-acting theophylline. Mind you, these corticosteroids, what we're speaking here, this is inhaled corticosteroid, not oral corticosteroid in this particular line. However, 5 to 10% of patients do not respond well to these treatments. These cases are labeled as difficult or therapy resistant asthma. So, although most patients with chronic asthma have significant improvement in their airway function with corticosteroid therapy, a subset of asthmatics are insensitive to corticosteroids. So, clinical studies have revealed that suboptimal response to inhaled corticosteroids in about 50% of asthmatics. So, that's the reason why we most of the cases, when we start on any inhaler, for example, Seroflor, Foracort, with a low dose patient will come back to us within few days saying that it's not responsive. So, this may be the reason that more 50% of cases may be suboptimal response will be there. It should be noted that the term steroid resistant asthma refer to a relative insensitivity to corticosteroid, meaning it is corticosteroid dependent asthma rather than absolute resistance. The basic term corticosteroid resistant asthma, it is very rare and in found in less than 1 is to 10, 1000 asthmatics. That means the patient is, however, it is totally genetically resistant to corticosteroids. So now coming to topic proper, that is definition of steroid resistant asthma. So steroid resistant asthma is defined as less than 15% improvement in baseline FEV1 after 14 days or 2 weeks course of oral prednisolone. The dose should be around 40 mg per day in patients who demonstrate more than 15% improvement in FEV1 following the inhaled beta 2 agonist salbutamol. Let me clarify this definition. See, it doesn't mean that those who respond to beta 2 agonist will respond to corticosteroids. That's what he meant here. Usually, beta 2 agonists are short acting. Salbutamol is short acting, so it doesn't modify the disease process. Corticosteroid is the only drug that can modify the disease process. That's the importance here. Furthermore, if the patients shows FEV1 improvement more than 30%, then they are considered as corticosteroid sensitive. So obviously, when we are speaking about steroid resistance, you should understand what is steroid sensitive. That's what he meant here. So, what is the mechanism of action of glucocorticosteroids, especially in the treatment of asthma? So, as you can see here, for example, in cases of cytokines, whenever there's an inflammatory mediation is there, the inflammatory mediators such as TNF alpha, IL-1, IL-2, all these they start acting to the cellular receptors. The cellular receptors for these cytokines are present in the membranes. These are membranous receptors where it is dominated by cytokine receptors, that is CYR. So they will be translocated into the cytoplasm where they will start their effect by transcription factors like NFKB or AP1, etc. These factors are started acting, they will go into the genome, that is the DNA, and these factors will start affecting on the specific transcription factors, that is here denoted by TFRE. So these factors, once they start transcription, they will ultimately lead to the development of steroid, that cytokine inflammatory genes, expression of cytokine inflammatory genes through this basal transcription complex. So This is the basic modality how the cell responds to a particular inflammatory response. So now coming to corticosteroids, corticosteroid receptors are usually present in cytoplasm. So usually they are present in our cell membrane. Once the corticosteroid attaches itself to the glucocorticoid receptor that is denoted by GR, these will be translocated directly into the nucleus. Once into the nucleus, they have two modes of action. One is they will be as with the NFKB transcription factors. These glucocorticoids acts on a specific receptors. These are negative glucocorticoid receptor enhancing, means they will stop the transcription of inflammatory genes. This is to a less instant. The major reaction is through direct interaction with the NFKB and AP1. These translocation they will be interfering with. This is the major action of the glucocorticoids. As such, the transcription of inflammatory genes will be stopped. So the release of the cytokines and other mediators will be stopped. So as we have explained in the figure, I'll be briefing it. That is, it has three main anti-inflammatory mechanisms. One is make passive complexes with transcription factors. That is, once it has entered into the DNA. The other main role is active inflammatory gene repression. That is, NFKB, all those factors will not be allowed to transcript. To a very minor extent, they will be activating anti-inflammatory genes. Now, coming to molecular effects of glucocorticoids. So there are two things. One is trans activation. These will decrease the inflammation through activation of specific genes or other mediators. Trans repression is nothing but they will repress whatever gene is the cytokines or whatever. So trans activation, it is either activation of annexin 1, beta 2 adrenergic receptor, secretory leukoproteinase inhibitor, and then phospholipase A2 inhibitor, that is CC10, vasoreglins, all these things. Coming to trans repression, we all know the cytokines are important. So cytokine repression, chemokine suppression, adjacent molecules, that is ICAM, VCAM1, inflammatory enzymes depletion, inflammatory, all these things will be repressed. So how the corticosteroids acts on these cells? So one side of the column shows how it acts on the inflammatory cells, including eosinophils, T lymphocytes, macrophages, mast cells, dendritic cells. All these cases, there are two major actions. One is either they decrease the number of the inflammatory cells by apoptosis, or they decrease the production of cytokines. Whereas in structural cells, as we know, this structural cells indicates that respiratory structural cell, that is epithelial cell, where there will be decrease in the cytokine mediators, endothelial cells where there will be decrease in the leakage, concomitant decrease in the inflammatory mediators, airway smooth muscle, which is the most important component for chronic asthma, where it will increase the beta 2 receptors and decrease the cytokines. And coming to mucus glands, it decreases the mucus secretion. So how does this corticosteroid resistance happen? So basically, before going to we should understand that there are two mechanisms by which corticosteroid resistance will happen. One is receptor resistance, that is the glucocorticoid receptor, whatever that is present over the cell membrane or cytoplasm, they will be resistant or decreased definitely to the glucocorticosteroids. And the second one, the most dangerous one, is inability of these receptors. Once the translocate into DNA, they will not be able to affect the transcription. So that is briefing. So I'll explain in detail. So most importantly, one of the most important part is this IL-2, IL-4, IL-13. These specific interleukins, once they enter into the cells, they will be activating a pathway called P38-MAPK. This P38-MAPK has a unique property that it will phosphorylate the whatever glucocorticosteroid receptor combination, whatever it is there, it will phosphorylate it and rendering the complex ineffective. The second one is, I have already told you that once the glucocorticoid enter, it will be enabled to transcript the negative GRA effect. That is, most two important factors will be there. Once this glucocorticoid receptor complex enters into the DNA, it will be acting on two specific lysine residues, K5 and K16, on histone 4. So this histone 4, once the glucocorticoid receptors act on this K5, K16, it will lead to acetylation of histone 4 protein. and then the further transcription will happen. So in some genetic modifications or who are genetically individuals, this K5 will be absent, resulting in inability of this receptor to uh, function its function through the DNA transcription. So as I told you, one is defective GR translocation, that the first type where I have introduced to you. The second one is altered histone acetylation, and that is in the second one where genetically deficient individuals. There's also in receptor splicing gene where the altered splicing of GR gene leads to beta isoform. Usually the glucocorticoid receptor should be in alpha isoform. They will be, if they are convert to beta isoform, this is inactive form which will not be able to exert its effect. The fourth one is overexpression of transcription factors, as we know, NF-κB and AP1. Reduced affinity of glucocorticoid receptors to glucocorticoids, enzymatic degradation of glucocorticoid receptors, extracellular pumping of glucocorticoids, and the last one is non-functioning GRs, that is genetic. So out of these two, the first one and two are most important. So what are the different factors contributing to glucocorticoid resistance? One is allergen exposure, where there will be mechanism is that there will be increasing the IL to IL4, resulting in decreased GR binding affinity. As I told you that through MAPK, that's what, MAPK, P38 MAPK phosphorylation pathway. And the second one is through infection. Infection leads to super antigens. Again, the same thing, MAPK activation, defective GR translocation. And in neutrophilia, the glucocorticoid receptor, it will be the beta isoform will be more predominant. In smoking, oxidative stress, increased histone acetylation, obesity, increased MAPK and TNF activation, stress, it increases blood cortisol, that it may renders the more receptors will be attached to the innate cortisol rather than the treatment, the whatever inhaled corticosteroid we are giving. And ethnicity, especially black races, some genetic and environmental modifications might be there. Vitamin D deficiency, it has been seen that vitamin D plays a role in enhancing glucocorticoid sensitivity. That's why in cases of acute exacerbation who are not resistant to regular steroid therapy, will be preferring to give vitamin D. So what are the different types of steroid resistance asthma? There are two types. One is in type 1 steroid resistant asthma patients, the glucocorticoid receptors binding affinity is abnormally reduced with an increase in receptor sites per cell. That is obviously we can understand when there is decreased affinity, obviously the cell tries to increase the receptor sites so that it can effectively bind the available corticosteroid. In the other type 2, the glucocorticoid receptor binding capacity is normal, but there is marked reduction in the number of glucocorticoid receptors. As such, the cells will not be able to use effectively. The glucocorticoid receptor defect in type 1 is reversible with deprivation of cytokines like IL-2 and IL-4, while it is irreversible in type 2 steroid resistant asthma. The type 1 asthma, which accounts for the large majority of patients, is acquired and it is restricted to T cells, whereas type 2 is genetic, it's maybe from congenital. It's a form of primary cortisol resistance and it is not limited to T cells and it is very, very rare. So tabular form of this difference, one is a basic defect, that is decrease the GCR binding affinity in type 1. Type 2 is reduced number of glucocorticoid receptors. Cells affected mostly, those are T cells are mostly affected, whereas in type 2 both T and non-T mononuclear cells are affected. Reversibility of the defect, yes, in type 1 if you increase the dose it will be reversible, but in type 2 it's nowhere reversible. Cause is usually acquired in type 1, in type 2 it is genetic. And improvement with high dose steroids and the resultant Cushingoid syndromes are higher in type 1, whereas in type 2, as there is no response to higher dose of steroids, obviously will not be giving high dose, and as such the Cushingoid syndrome will not be seen. And morning cortisol levels, usually they are suppressed in type 1 and it is normal in type 2. So coming to the diagnosis, so it's very difficult to diagnose between differentiate between type 1 and type 2. But how do we, the basic thing is how do we diagnose a steroid resistant asthma? The diagnosis of steroid resistant asthma in these patients can be established by means of follow-up for a period of greater than 6 months, during which time asthma management is carried out according to published asthma guidelines, that is GINA guidelines, and issues such as compliance with the treatment, identification of exacerbation factors, exclusion of other diagnoses that are to be dealt with. So this protocol is different. The basic thing I'll tell you that in a normal asthma where the treatment will be used as SOS medication, as the disease severity increases, we have to increase the dose of inhaled corticosteroids. We have to increase the dose of long-acting beta agonist. In the similar way, we have to add on anti-muscarinic agents and oral steroids. If all these are there, excluding the other factors, then we can diagnose. So the following tips may help in the diagnosis of steroid resistant or insensitive asthma. Patient should have pre-bronchodilator morning FE1 less than 70% of predicted, with a 15% improvement following a rapidly acting bronchodilator treatment. This value of FE1 is recorded as baseline. Mind you, the first point, it indicates the base for the diagnosis of asthma. And the FE1 less than 70% is the baseline. These patients should be given oral steroid therapy, that is prednisolone 40 mg per day for at least 2 weeks. If these patients fail to show any increase of pre-bronchodilator morning FE1 by 15% over baseline value, even after 2 weeks of oral steroid therapy, a steroid-resistant asthma should be differentiated from brittle asthma. Now the term is brittle asthma is a bit contradictory. Now it is called as acute exacerbation of asthma, not responsive to any treatment. So where the patient experiences recurrent episodes of severe airway narrowing that appear rapidly over minute to hours, occurring any time of the day with no obvious trigger. These patients have either normal lung function between episodes, which cannot be prevented by steroid or a persistent background, or wide variability in airways obstruction. Such episodes may respond to either subcutaneous adrenaline or terbutaline. So, what is the management? In case of asthma, clinical studies have suggested that favorable response to inhaled steroid is associated with high levels of exhaled nitric oxide, which usually is we test it through a test called FeNO, high bronchodilator response, and sputum eosinophilia. The patient with suspected steroid resistance should be managed in a stepwise manner as mentioned below. So in the next few slides, I'll be discussing about 9 steps. But mind you, all these are only what we say. These are uh, uh, diagnosis or management by exclusion rather than any particular management. So step one, confirm diagnosis of asthma and rule out concomitant medical disorder such as vocal cord dysfunction, GERD, chronic sinusitis, trichomalacia, ABPA, tropical pulmonary eosinophilia, or Church syndrome, etc. All these factors actually they will be causing the exacerbation of asthma irrespective of the treatment. So before labeling a patient as steroid-resistant asthma, we should rule out other causes that will cause frequent exacerbation of asthma. The step two, identify and remove potential allergens at home, in school, and at workplace that might trigger the patient's disease. Regarding this, we all know that asthma is mostly aggravated by allergens also. So we should take proper history and guide the patients whether if they can be shifted to other place in case of any impending thing. Step 3, review the patient's compliance and inhaler technique. So this is very, very, very important because most of the cases when we come across, we usually prescribe the patient inhaler or autocap, whatever it is, and we think that patient will be taking it properly. But ultimately, once we review, there will be a lot of lacunes, so it affects the drug delivery, and the patient doesn't want to take the uh, drug properly. And spacer device should be used to optimize medication delivery and reduce adverse effects. This again, it is plus or minus when it comes to young patients. Step 4, evaluate for psychological factors affecting adherence and response to therapy. Develop strategies to improve compliance by simplifying medication regimen and implementing a written action plan. Step 5, evaluate for potential microbial infection. Most commonly, it will be viral or atypical bacteria like Mycoplasma or Chlamydia, which can trigger airway inflammation and steroid insensitiveness in chronic asthmatics. These individuals might respond to prolonged course of antibiotics such as clarithromycin or azithromycin. Step 6. Consider factors that affect lifestyle and steroid responsiveness. Maximize combination, that is long-acting beta-2 agonist or theophylline therapy, assessment and correction of vitamin D deficiency, control and treatment of obesity, cessation of smoking, etc. may improve steroid responsiveness. The above steps are helpful in type 1 steroid-resistant asthma, while patients with type 2 steroid-resistant asthma needs further workup and alternative approaches for treatment. Step 7. Evaluate systemic corticosteroid pharmacokinetics to determine whether there is incomplete corticosteroid absorption, failure to convert into active form, or rapid elimination. Patients with poor absorption usually respond to oral liquid preparations. In case of rapid elimination, a split dosing regimen is suggested with the first dose in the morning and the second dose in the afternoon. Step 8. Assess evidence for persistent tissue inflammation despite treatment with high dose steroids, such as exhaled nitric oxide, FeNO, sputum eosinophils, ball or bronchial biopsy specimens, studies on peripheral blood mononucleosides, etc. Step 9. The final step is to consider alternative anti-inflammatory and immunomodulatory approach, such as IV immunoglobulin, cyclosporin A, methotrexate, azathioprine, gold, anti-IgA antibodies, omalizumab, for example, in allergen-triggered airways disease. Particularly in type 2 steroid-resistant asthma, leukotriene modifiers like montelukast is also a good choice in such cases. So these are the 9 steps that are used for management. The novel therapies in steroid-resistant asthma, like antagonists to pro-inflammatory cytokines like IL-2, IL-4, IL-5, IL-13, TNF-alpha, and anti-inflammatory cytokines, may find a great role as anti-inflammatory and steroid-sparing agents. Further, bronchial thermoplasty has also shown significant improvement in asthma control in severe asthmatics. Recently, IL-1 targeted therapies in corticosteroid-resistant neutrophilic asthma are also being tried. So, coming to alternative therapies, low dose theophylline. Optimally, the low dose theophylline will be it should be given at 5 mg per liter. It reverses histone acetylation, many effects on inflammatory cells, decreases vascular permeability. Effect is better than selective PDE4 inhibitors. Antileukotrienes, we all know the most common molecule is montelukast. Jaflukast is not being used nowadays, and pranlukast, to a lesser extent, it's being used. These block leukotriene receptors. So 20 mg of jaflukast and 10 mg of montelukast have steroid-sparing effect of 400 micrograms of beclomethasone. Macrolide antibiotics, most commonly nowadays vancomycin or erythromycin are not being used. The same efficacy is seen with azithromycin. The mechanism is the decreased methylprednisolone clearance, decreased neutrophil migration and chemotaxis, decreased release of free radicals by neutrophils. So we all know that macrolide antibiotics, besides working as antibiotics, they have immunomodulatory function that will be reflected in the treatment of asthma. The dosage is usually leaving out this erythromycin, taurindomycin. Usually it will be given, azithromycin it will be given either 250 mg daily or 500 mg on alternative days for a period of 3 to 6 months. Nebulized lidocaine. Many studies have shown benefit from nebulization of lidocaine 2%, that is 1 mg per kg, once daily for 12 months. The mechanism most probably by vagal block, and also they decrease the eosinophil survival. Very promising with substantial steroid-sparing effect. So coming to immunosuppressants, methotrexate, it's usually given in low dose, that is 15 mg single or divided in twice per week for 6 months. The mechanism being decreased neutrophil chemotaxis, decreased B cell differentiation, decreased eosinophil related cytokines, proved effective in steroid-resistant asthma in many patients with significant steroid-sparing effect. But mind you, the side effects are also very important. So it should be only used exceptionally. not on a regular basis. Azathioprine, the rest of the molecules what we are going to discuss now are only used very rarely and only once molecular diagnosis is established. So azathioprine suppresses monocyte function, dose 2 to 5 mg per kg per day, at least 8 weeks, that is 2 months. Side effects are very common. And cyclosporin A decreases T cell and eosinophil proliferation, interference with mast cell function. The dosage is 5 mg per kg per day for about 3 to 9 months. Other anti-inflammatories, RMN, that is gold, acts by T cell suppression, 3 mg oral twice daily for about 6 months. It has good steroid sparing effect. Side effects are frequent but mild. Dapsone, it inhibits neutrophils, decreases free radicals. 100 mg oral twice daily for about 7 months. Good steroid sparing effect. Hydroxychloroquine, it's a PLA2 inhibitor, 300 to 400 mg oral daily for about 7 months. It has good steroid sparing effect. Side effects most commonly that may be related to gastritis. Colchicine, T cell suppressor, decreased leukotriene before molecules. So the dose is around 0.5 to 0.6 mg oral twice daily for 2 months. Synergistic with theophylline, so it is safe. Immunotherapy, IV immunoglobulins. So mechanism, T and B cells decrease activation and differentiation, decrease production of IL to IL4, decrease complement activation and decreased IgE synthesis, reduce steroid requirement and decrease hospital admission. Dose is 1 to 2 gram per kg per month for about 6 months. So as you know that it's very hazardous to use it. So as of now, we are not using IV immunoglobulins as a regular therapy. The next one is omalizumab. This omalizumab is a antibody and antigen antibody interaction will be mast cell degranulation. It's an anti-IgE antibody, so it is poorly controlled. It's when it is used when the IgE levels are very high. Mind you, that the requirement is greater than 2500 on a regular IgE serum IgE levels. It should be poorly controlled asthma, and the age of the children should be greater than 12 years old. It is usually given by injection. The injection consists of 150 mg in a 1.0 ml vial. Dosage is 150 to 375 mg subcutaneously every 2 to 4 weeks for 12 injections according to serum IgE and body weight. So the side effects are mostly is it's very expensive. Its local reaction will be there. Anaphylaxis, decreased anti-tumor and anti-parasite immunity. So, but because of this expensiveness, government has launched. I'll be telling you that government has launched a particular therapy program. This omalizumab is will be given free of cost in a government chest hospital in Hyderabad, actually. So allergen antibody complexes from serum of allergic patients, it will be removed. Interference with allergen presentation processing, few reports of efficacy, but it is specifically for atopic asthma, not for every type of asthma. And anti-CD4 monoclonal antibodies, it inhibits T cell activation, 3 milligram per kg for 2 to 3 weeks by IV infusion. Plasmapheresis can be tried in very severe cases, removes antibodies and immune complexes. Desensitization, severe steroid dependent asthmatics are not candidates for immunotherapy, but if used early can be prophylactic. So the last one is bronchial thermoplasty. I think I have told this many times in my presentations. It's the latest arsenal in steroid asthma, sorry, in chronic asthma, where irreversible change to muscle, smooth muscle has happened. So the debulking of the airway smooth muscle will be done by radio frequency generated heat. It is approved by FDA of value in severe persistent asthma with remodeling. Done in 3 sessions, 3 weeks apart. Results are very encouraging with great reduction in steroid doses. But it was earlierly it was seen, but it has been now that after a bronchial thermoplasty 2 to 3 years later, again it is recurring. The airway smooth muscle is coming back to its original thing. Future therapies. What is the tendency of future therapies? As I told you that P38 MAP kinase phosphorylation pathway is causing that glucose receptor translocation to fail. So inhibitors are being tried. It have good effect on IL to IL-4. Early formulations are toxic, so it's in the still trial methods. Selective inhibitors of IKK beta, there is a translocation factor. Selectively inhibit NF-kB kinase, which is important factor in steroid resistance. And MIF inhibitors still in early phase studies. IL-2 receptor basiliximab. It has been approved by FDA. Right now, it's not being used in any. It's only in few trials it has been used, but it is effective. And glycoprotein 170 inhibitors, it inhibits excess cell efflux of glucocorticoids, that is quinidine. Thank you.